All right. I think we'll kick off. We're going to leave the door open for a few minutes because of the people who are enjoying their morning tea. We'll kick off, but we're going to... if everyone's happy, we'll leave the door open for a bit longer and welcome the latecomers. I'd like to start by acknowledging the traditional owners of this beautiful country on which we've all come together to meet this week, the Larrakia people and their elders past, present and emerging. My name's Bek Ledingham. I'm a GP from Broome. Actually, I'm lots of things. I have a very full hat stand, but today's hat that I'm wearing is as the chair of the Female Doctors Group of RDAA. And this is our annual RMA workshop, so we do it every year. And I've been involved with the Female Doctors Group since I flew to Canberra with a 4-month-old baby on my lap, supported beautifully by Annette in the front row here, and met these amazing women who helped me with some significant struggles I was having as a woman with a child in medicine. And they became the champions of my career. And we are always looking for more people to join the Female Doctors Group, so we get together and we talk about issues that affect female rural and remote doctors and their patients. So if you want to be a part of that, you have to be a member of RDAA, first step, and just let us know your email address and we'll let you know about the meetings. We've just got a really high-tech piece of white paper up the front and a pen. And I just can't recommend joining the Female Doctors Group enough. It's passionate women doing good stuff for rural and remote Australia. After our workshops, we typically meet and gather at lunch, and every year at lunch we share stories, and every year there's stories of struggles and harassment and bullying and discrimination every single year. What is it that we're talking about? This is the government definition, which we really need to familiarise ourselves with, but over the last, since the conference started, I've been collecting examples from people about what it is. I think it'll be familiar to all of us, and these examples that'll flick through are just the tip of the iceberg. Today we want to bring this conversation out into the public domain, out onto the stage, to speak it out loud. It's a conversation and a problem familiar to many of us, and we've had this conversation in private, in the shadows, in whispers, in fear, and sometimes in shame. But it's time to talk about it with everyone, and I really welcome the men in the room because we really need everyone to be part of this discussion, and we need the collective to find the solutions. Who is responsible for fixing this problem? I'll tell you who it's not. It's not the victims, and very often when you talk about the solutions, the sentences start with you should, he should, she should. And it's not helpful, and it often compounds the trauma of being a victim of bullying and harassment. Most often, the victim is in a position of less power than the perpetrator, and they are unable to affect any kind of change. And if you tell the victim that it's their job to affect change, it's rubbish. We've got to stop doing that. The conversation needs to change to what we can all do, all of us, everyone in medicine. We have a really fabulous panel. I'm so proud of the Female Doctors Group for bringing together this panel. And they have ideas and experience and wisdom in this area to kick off the conversation. And then we'd like to talk to you in the room, the wisdom and the knowing that we've got. Get your questions, get your suggestions, get your experiences. And then if we can reach a consensus, we'd quite like to do a media statement at the end of this workshop, if everyone's happy with that, about how we feel about the problem and our commitment to change it. Today we want to look forward to a future when these examples are not expected, they're not the norm, and they're no longer accepted. And hopefully we'll even take a couple of steps into that direction towards that future. So the first amazing member of our panel, the bells are a bit late, that's going to talk to us, and apologies on her behalf, she can't stay till the end, but I'm really glad she's here, is Louise Stone. She's a qualitative researcher, a GP specialising in mental health, and someone who has researched sexual assault on doctors by doctors. Some of you may have been lucky enough to hear her talk outlining this important work yesterday. She's also a mum, and I've spoken so quickly. She is the owner of this therapy cat that's about to come up. Because after all that heavy stuff, we needed a cat. Although this cat thinks that she's actually the owner. So welcome Louise to tell us about her work.
Thank you. The one who was holding the cat's my daughter, by the way, just so I get where you're coming from. Look, this presentation can be a bit distressing, and I know that the purpose is not to be distressing. The purpose is to at least discuss what's going on. But if you prefer to engage with the presentation another way, I'm really happy to send you the transcript. I always do. And you can always contact me at louise.stone@anu. I've got a boring name, we might as well use it. And if you want to email me and talk about anything or get me to send you anything about this research, you're very welcome. So how did this all start? Well, it started from a typical general practice situation, and I really took a lot from Jillann's work yesterday, or day before, it feels like all the days have run together. I was in the right place at the right time, so I looked after an intern who was raped by her boss in 2014, and now I do lots of mental health work. I helped to run a Masters of Psychiatry. In fact, I ran another Masters of Psychiatry back in the 90s, so it's not like I'm not used to dealing with women with trauma, but this felt different. And it took me about 14 minutes, I think, to just bring the shame in the room down enough for us to actually be able to start some work. And I think the thing was that, she was a doctor, he was a doctor, I was a doctor. And so I went looking for literature and thought, oh, okay, I'll be an academic. I'm not really much of an academic, but I thought, well, I'll give it a shot. So I went looking for it and there wasn't any. So I did what GPs do and talked to everyone I knew at all the conferences I went to that year. And all the seniors had seen a case, but nobody had written anything down. So I figured that I was in the right place at the right time. I've got a background in qualitative health research. What the heck? I guess it's me then. So although we know very little about the abuse and harassment of qualified doctors, we know a lot about medical students. So this is a meta-analysis internationally that says about 60% of people experience harassment and discrimination, and about 33% of medical trainees experience sexual harassment, women more than men. But what we don't know is the lived experience of what it's like, not just to experience the harassment, but what's the recovery like? How could I help this person? Because that was where my question came from. We do know, of course, and I'm sure Danika will talk about this, that depression and anxiety is common, that doctors are very ashamed and worry that being depressed or anxious or having any mental health concerns will actually ruin their career. And I certainly look after a lot of young doctors who have that concern. And we know that there's a very high suicide rate. So 4% of doctors have attempted suicide at some stage in their career. So it's quite high. So I knew this was going to be a bugger of a study to design so that it was ethically sound. It took me 6 months with a hell of a lot of support from a hell of a lot of very high up people who did nice things, like when I rang them and said, just explain how the court system works, actually went through it with me. So what I wanted to talk to you about today, we probably all know the story of Caroline Tan and her abuser. She won her case in a civil court, and then she basically lost her career and he was promoted. And this is John Kearsley, and I'll be talking a little bit about these cases because I interviewed some people. I interviewed the victim of this case, and I can say that because she's never revealed her identity, so that's kept it out of the research space. But John Kearsley invited her back to his home for a tutorial, and she woke up after being drugged with benzodiazepines to naked on the couch. So he pleaded guilty, but then got 100 testimonials, mostly from women, saying what a wonderful man he was, and his sentence was truncated to 4 months on appeal because he was a good man who was depressed. He's since been charged with inappropriate touching of a patient and been given community service. So it's a very difficult space for people to operate in, and I am so with Bek's comment about victims need to decide their own path. So I just wanted to share a few findings of this study, having talked to these women, and just so you know what I did, I spoke to them over years, and the data consisted not only of the interviews but also their legal transcripts, anything that they wrote, any media reports, all that stuff. Hell of a lot of words. And I wanted to talk about the two findings that I think might help us have this conversation. The first is that there's phases of trauma, and I don't think we talk about them much. So the first phase is what happens before the trauma, where women are reflecting on why this happened to them. 2 of the participants in my study had been abused at high schools and had been basically told to shut up one way or the other. One by terrible victimisation with parents who kept, yelling at her at the school gates and telling her that she'd ruined the career of this lovely teacher and how could she was such an awful person. So she'd learned not to speak up. There were a few things that turned up in the prelude. Women doctors talked about how hard they had to work to be nice. They said that in order to get on with the nurses, they had to be competent and secure enough to look like they knew what they were doing, but not a feminazi. They had to be nice. They all had to do morning tea and they had to be pleasant. And they said that being compliant and pleasant actually put them in, getting on with the nurses put them at risk with the doctors, if that makes sense. So that was something that I thought was really important to raise. And obviously the hierarchy of medicine and all that other sort of stuff that turns up in the military, the same sort of deal, being dependent on your supervisor. Also the slightly starry-eyed thing you get in medical school of looking up to mentors, which is a really positive thing, but each of these women said these were people I really respected. I wanted to be like this person, and that gave the mentors an opportunity to do grooming. So they would pick out the registrar and they would say, no, remember, this is not sexual harassment, this is nasty stuff. This was, you're really good with my patients, you do such a good job, I'm going to give you this special case to manage because you're so competent, okay? So that sort of mentorship relationship raised their risk. In terms of the assault, in my study we had escalating harassment. Interestingly, one of my participants was harassed and stalked for 7 months in a room with a sexual harassment poster on it. So policy doesn't work, sexual harassment is illegal and it doesn't make any difference. So I think that's really important. So escalating harassment or assault. And the hard part about this was that some women were still questioning years later whether it was actually assault. So one of my participants was on a rural rotation, was assaulted they all went out for a team dinner, they came back to quarters, the registrar threw her against a wall, touched her up, did all sorts of things, and she got away. She had to work with him for another 3 months. And she was still saying at interview, I would say, if that happened to your best friend, what would you say? And she'd say, oh, that's illegal, that's terrible. What about you? Oh, well, I'm still not sure whether or not I did something wrong. Maybe I should have been more professional and not smiled as much. So these women often really question themselves and it's very difficult for them to recognise. And I get it, because if you recognise that it's abuse, you feel very powerless. If you think you've got some control, there's something about that that's attractive because it makes you think you can change and maybe it won't happen to you again. This is the phase that really surprised me. It can take up to 3 years for things to get to the court, and until they get to the courts, you're under confidentiality agreements. So these women basically have to just shut up. And they often have to work in the teams with the perpetrators, which is ghastly. So all of us as GPs have this wonderful opportunity to be their person outside of the hospital network, because we are outside of the hospital network, and this is where I picked up the intern that I cared for. It's difficult for them because they can't move on, whatever that means, until after the court case. They have to sort of stay a bit angry. So it's a really difficult time for them. Incidentally, all of my exposure is the next stage, and that's often more traumatic than the abuse, and all of my participants had their professionalism ratings plummet as soon as they reported. I'll come back to why that matters in a minute, but the exposure of people starting to get to know, getting in the media, getting into the hospital networks, people knowing who they are, was worse than the abuse, and it was the women who caused the worst of the trauma that came up again and again and again. So it was the senior women who wrote to the media about Caroline Tan and said, well, you do know she used to sleep around and she wore short skirts and she had low tops, and what do you expect? It was a woman who published the article on Caroline Tan that said, if you can't get a neurosurgeon to fix your brain tumour, you can blame people like Caroline who've ruined the profession. So, it's not just a man's problem, and I think that's really critical. And it was often the men who were the statesmen in the space as well. So I think that's actually important. The gossip is incredibly painful. The woman who was harassed for 7 months and stalked, when she went back to the hospital after reporting, she'd been away at a conference, she came back, they said, you're no longer welcome here, and she wasn't allowed to set foot in the hospital for 1.5 years. She was still paid, she just wasn't allowed to set foot in the hospital because she caused the perpetrator to become suicidal, and therefore she was toxic. So the gossip is awful, and all of these women, the women who reported, passed their fellowship exams on the first go, but they all had years out of the profession because they couldn't face it. The aftermath is what you'd expect with PTSD, but the thing that I think is really important to know is that for some of these women, so the Kearsley victim had this amazing statement where she said, you know, my world is broken and will never be the same, is her famous statement, which is just heart-wrenching. But they panic when they pick up a phone, they panic seeing an email that they don't expect, you know, that sort of stuff. She said, I feel like when I've gone back into hospitals, I have to hug the walls because the floor is not safe for me anymore. So there's a real role for us welcoming these women back into our communities in a way too. It's not just about zero tolerance. So look, I didn't do this study. Being a GP, I didn't do it just for the academic kudos of it all, and I certainly didn't do it just to publish sad stories in medical journals. What I wanted to see was what we could do to make a difference. And what I realised is that zero tolerance is not enough. And I've started a hashtag zero tolerance, which I'm going to get moving now because you've all motivated me now, to talk about the dilemmas, because there are some core dilemmas that we all need to deal with in order to make our communities safe. And I just wanted to talk about them in terms of the CanMeds framework, which a lot of people might be familiar with. The CanMeds framework says, you know, our job as clinicians is in the middle, a medical expert, but we take a number of other roles. We're advocates, we're teachers, we're professionals, we're colleagues, we're managers, we do lots of stuff. And each of those roles has a specific dilemma in this space, I think, that makes it very difficult to solve. So I wanted to walk through those dilemmas with you just to give you a little bit of space and to have a think about them. And if you want to comment on a dilemma, do it on the Twitter tag and we might start some discussion up. So the leadership one, there's two, and one's the mentor dilemma, how close is too close. When we take our registrars home to have barbecues with our families, which is really, really lovely, and we get very close to them and we care about them and we ask them about their lives, we may not be thinking that they will therefore become more vulnerable with other people who may not have such good boundaries. Now, it is very important that we develop good mentorship relationships with our registrars. It really makes a difference. There are people who still walk around talking about their mentors 30, 40 years later. It matters. But at the same time, we also have to think about how we teach those boundaries and how we monitor those boundaries and whether we're keeping our registrars safe. So it's a dilemma. It's not an easy problem to solve. But I think we need to think about mentorship and where those edges of mentorship might be. In terms of the manager dilemma, if someone can't sack the senior surgeon, then there's absolutely no point reporting. And managers have trouble doing that because the senior surgeon might be the only surgeon and the community will be up in arms. And the community will then turn around and blame Caroline Tan, which is what happened in Canberra. So we have to work out what our systems are, and I think run some things in our hospitals to go, well, if this happened, what would happen? How would we do this? What structures would we need to put in place if the behaviour of someone with the most power in the hospital is found to not be behaving the way that we need? How would we actually do that? Rather than just saying we have zero tolerance, I don't think that helps. Because I'll guarantee you the HR department will go for the intern because they're replaceable. The spokesperson dilemma, gossip is incredibly painful, but so is silence. It's not easy to work out who says things and who they say them to. But it is not helpful for the head of ophthalmological surgery, female in this case, going on to public radio and talking about how Caroline Tan sleeps around. You know, we've got to be better at managing that. You know, there was absolutely no articles about John Kearsley that didn't start with the eminent Professor John Kearsley. And when he lost his professorship, the article from the spokesperson at the University of New South Wales, he who must not be named, said the conduct displayed was inconsistent with our code. It did not say John Kearsley raped a student, or John Kearsley raped a registrar, or John Kearsley sexually assaulted someone and we're not going to have that at our university. It was very back. We need to think about that and start thinking about what we're going to say. I'm not saying be inflammatory, but at least be a little bit more honest than the media that came out before. The witness dilemma is whose side are you on? So my woman who was sexually harassed so severely, it split the department. There were those who allied against her and those who allied against him, and the department still had to function. So somebody has to manage that team to make it possible to manage that trauma, and that's actually incredibly difficult. The Educative Dilemma for the educators in the room, the hard part, of course, is how do you assess professional performance fairly without being sort of subject to bias, because you will be, there's no question. The question is how to mitigate that and how to actually work with it. I think we need to think about how we support the people, poor things working in colleges and medical boards trying to make decisions about this, because it's really hard. You imagine sitting in a medical board trying to decide whether to deregister someone. It's not easy, and I think we need to have some more open conversations with our institutions about that. Whistleblowers traditionally get sacked, so we've got to think about strategies for whistleblowers. We're getting really good at it with medical errors. We're not so good with this sort of stuff. And finally, the one I started with, which is, you know, how does being a doctor change therapy? And that's something I've really been thinking a lot about recently, and we're starting to get together and have conversations about whether that's a good thing or not. And there are advantages and disadvantages to it. This is the take the photo of it if you want to slide at the end. But I just wanted to say 3 things that I think are really important. Firstly, zero tolerance doesn't work. We know that the literature around the world says that zero tolerance doesn't work. For goodness sake, this is illegal and that hasn't stopped it happening. So I don't see how calling it zero tolerance is going to work. And the surgeons who've done their Operating with Respect campaign have picked up a whole lot of bullying and discrimination, but no sexual harassment, none in 3 years. So people are not reporting. The second thing is it's not all the bloke's problem. It was the women who did the most trauma after the event. We're not going to solve this problem just by saying, oh, when women come into leadership, it's going to change the world and it's all going to be better. Not saying that there aren't great women in the world, and not saying that, you know, there aren't great statesmen, because there certainly are, but we're not going to solve the problem just by shifting the gender mix. We've got to do more than that. And the third thing is we're not going to solve the problem by flattening the hierarchy. You know, when it hits the fan in the middle of an operating theatre, I'm sorry, but we need a hierarchy, we need a general, and that everyone will ally behind the senior surgeon, because you have to. We don't solve this problem in the military by removing the generals and just making it all flat. And besides which, just quietly, there was a lot of talk about nursing staff and nursing staff to male doctor abuse, which I did not interview men, but I would like to one day. So I don't think we're going to solve this by saying, let's just remove the hierarchy of medicine and then there won't be a power differential and we'll all be nice, because that doesn't seem to work. So again, if you want to get in touch with me, just flick me an email and I'll share the website. I've put everything about the study up publicly so that people can see it. And just so you know how you do this research, you know, everything that I write goes back to the participants for comment, and it's about as collaborative as I can manage. I'm hoping in the next little while, I've just been to the Wonka conference, to set up a website where people can tell their stories safely. And I'm just going through, you know, trying to think through the legal stuff and the ethics stuff, because I've talked to people in Africa and India and Japan and Argentina and so on, and it's happening everywhere, but they can't talk in their own countries. So it would be, and in research, I can only ever give a very light general overview of what people say. I can never tell anything in depth because there's no words. Like the word count's ridiculous. So I'm hoping in the future to be able to create space where we can have a curated library of ideas from women about, firstly, how this happens, and secondly, how they recover over time. So I'm going to finish up there. I'm here for another hour and then I've got another parallel session, so I'm so sorry. I hate being rude and leaving in the middle of something, but I didn't have a choice. I might hand over to Bek just for comment.
It's on now. Thank you so much, Louise, and I'm really glad that you joined the panel. I think that's a really good start. Because Louise has to leave, I would like to ask if anyone has any questions for her or anything that they wanted to pick up from what she said.
Oh, come on, I haven't stunned you, liver. Nola, my fellow Gippsland person.
Thanks, Louise. Have you had any people reporting any problems coming from within general practice? Because you've talked a lot about the hospital system. Have you had anything come out of there?
Not in my research, but certainly informally when I've presented it at conferences, yes. And the other thing I meant to say is 3 women who didn't report left the hospital system and went into general practice. So I actually wonder whether we've got more survivors in general practice because they flee the hospital networks. And the other thing is what a big role we have being outside that. So I suspect we've got quite a few survivors who've run away, which I completely support. Being a GP, I'd never go back in the hospital.
All right. Any other questions, or we move on? One more. Oh.
It's not quite on that issue, but I've recently had an issue in our aged care with a dementia patient. So a man in our town who was known to have increased sexual appetite, then started to move on into our nursing home on numerous residents. And when we asked about it, we were told, well, he didn't actually pull down the patient's pants. But he did actually assault them. So we've not got very far with that, except for the family did take the resident out of the aged care. So I don't know if that's another sort of area we should be looking at.
Yeah, look, can I just take 1 minute just to share a personal story? So my youngest daughter had a liver transplant when she was tiny. And I remember her surgeon, who was the loveliest man, had a wife and 4 kids because he had a photo on the wall. You know, and I remember the day she had the transplant. You know, he rings me at 8:30 in the morning. She goes into theatre at 11:30, 13 hours in theatre. He's still in theatre. He comes out. There's only one liver transplant specialist in New South Wales, so he does this a lot. Comes back 7:30 in the morning, you know. That is his life. He spends his whole time with people saying, thank you so much, Dr. Shawn, you've saved my child's life. Now, I reckon if you're not pretty damn stable, 40 years of that, and I reckon you're in trouble. This is, I honestly believe in my heart of hearts that medicine as a culture, there's something about the way that we also feed this behaviour. I'm not saying that it's that men have no responsibility or whatever. And I also, by the way, didn't interview same-sex abuse only because no one volunteered, and I didn't interview men who were abused only because no one volunteered, not because I didn't want to. But I think we have to look at what we're creating inside those cultures as well. Yeah. Yeah, well, the reason I gave you those chairs is I think that those discussions need to happen around each of those chairs. I think if we resolved a lot of that stuff, plus the usual, this is what sexual assault is. I mean, we do have people in medicine who are socially inept, you know. And I do think that we need to be pretty blunt. And we also have a culture where young, attractive, white, privileged boys go to schools where young, attractive, white, privileged boy, unacceptable behaviour is allowed. So I do think we need, you know, to re-normalise that in probably medical school. What we do not need is to try and drive from underneath saying, oh, we've just got to teach the medical students how to stand up for themselves. That's not fair. The other people that I think we need to enlist are the anaesthetists. I've had a really long chat with them because they're the ones in theatre who are not doing as very much. Sorry. In the middle of the consultation, which gives them the opportunity to see what's going on. So, yeah, keeping patients alive, yeah, I know. But their whole work is at the beginning and at the end, and they often have a little bit of headspace in the middle. And there's been a couple of cases where the anaesthetists have called out the surgeons. Now, they're the same seniority, but they're not in the same rank. And I think there's actually space, anaesthetics being the classic one, because I do think the anaesthetists see the behaviour much more clearly because they're not, there are times where they've got a little bit of headspace, you know. And I think their awful work that I would never want to do is before the surgeon walks in the room often, you know. And I think they've got, and I think consultant to consultant, we've got to start saying, are you always getting traumatised patients coming out of geriatrics? Are you always registrars coming out of geriatrics? Or they've got to know, surely to goodness. But we have to do something about the consultant level rather than trying to feed it from underneath, because that's not fair.
I was just going to say there is a huge diversity in this, and we do need to be aware of the same-sex thing and the vulnerability.
Yeah, absolutely.
I remember there was a senior surgeon, and I was interested in doing a term with him, and someone is in a new hospital. Someone said to me, "Oh, don't even apply it. You're not going to get it. He only takes girls who are tall and slim and look like boys. You have to wear pants, and you have to look like a boy. And the registrars that work with him, you got to be on your guard all the time, boys or girls." And I was like, "Okay, not doing that then."
Yeah, absolutely. And I heard that too. And I heard some of the bad behaviour, I'm not picking on nurses, but nurses to male registrars, that seems to happen, that is sort of slightly more acceptable than male consultants to female nurses now. And in fact, the women in my study, 3 of them said sex with patients is no longer okay, sex with nurses is not safe either, but sex with junior doctors is fair game. We're the only ones left. So I think, and again, we're human. We live in our hospitals for 20 hours a day. We sleep in our hospitals. We are vulnerable, and doctors marry doctors. So, there absolutely is a complexity in that. And we talk about sex because it's part of our job. So there's some real difficulties in there as well. But I do think my participants were very different to oh, you're wearing a lovely short skirt, love. They weren't the mild stuff. These were sexual predators who planned and operated under the radar with all sorts of issues.
I know there's more that you want to say, but I'd ask you to hold it so we can get through the speakers. And if you want to say something in particular to Louise, she's generously given us all her email. Thank you so much. And thank you all for coming. On 2 levels, I'm really grateful because I said that the room was too small, and then I was a bit concerned that it wouldn't fill up. So thank you for not making me look silly. But also, I'm really glad to see this level of people interested in this conversation, because I think that's what we need. We need a groundswell. Our next panellist I will introduce is Dr. Danika Thiemt. She's an emergency medicine advanced trainee here in Darwin, working in both clinical and retrieval medicine. She sits on the board of directors for the Federal AMA and missed yesterday because she was in Canberra, so she's a frequent flyer. And she's the chair of the AMA Council of Doctors in Training. Dr. Thiemt is active in the Australasian College of Emergency Medicine, and particularly active in shaping the college's response to concerns around discrimination, bullying and sexual harassment. She's a proud Territorian and proud mum to Pepper, the Border Collie, who has recently learned how to high 10.
Thank you, everyone. So I often get asked to speak at things like this, just based on the experiences that I have perhaps had in my short career, but I stand up here every single time and wonder what on earth I did to feel like I was qualified to stand in front of all these doctors, especially on an issue as vitally important as this. There's been really not too many moments that I can put my finger on in my career that changed the landscape as dramatically in our profession as Dr. Gabrielle McMullen did in 2015 as she launched her verbal firework out into the media. For the first few years of my career, I had just gotten on with being a doctor. Some days were horrible, some people were horrible. It's just the way it was, it's the way medicine was. It was the culture of medicine. One day I'd learn how to put in an outline, the next day I got sent home early because the surgeon I was working with was offended that he could see the outline of my underwear through my beautiful yellow skirt. Normal life stuff. The day that Dr. McMullen's story broke and the months that followed weren't my first inkling that the system was broken, but it was the first time I thought that maybe we could do something to change it. Perhaps I was a bit late in the game, but I wasn't taught to think critically. I wasn't taught to think critically about the way that medicine was done. I was taught just to get by. I was taught just to do what I was told. This was the culture of medicine. Now, fortunately or unfortunately at the time, I had just been elected to the chair of the AMA Council of Doctors in Training. So I was the sole voice for the over 30,000 now interns, residents, registrars, fellows and non-vocational trainees across Australia. So despite feeling like perhaps I had no idea what I was talking about, not knowing what I was going to say, I suddenly had to have a really big say in this. And I suddenly had to be really opinionated because this had just blown up in the media. Luckily, I've never really had much of a problem being opinionated. And with time, I've worked my way through the AMA, working through many different areas of policy and media, but this remains one of my passions. I actually left my representative role with the AMA in 2016, but was quite quickly asked to join the ASIM expert advisory panel on equity and diversity after they received some claims about racism in their examination processes. Now, this was incredibly eye-opening for me because you may have noticed a few things about me. I'm a cis female, first of all. I identify as female. I speak English with an Australian accent. I grew up in WA. I trained in Victoria. I live in Darwin. I am very Caucasian, red hair and everything. So it was interesting for me to walk into a room and hear about discrimination that people will experience in a different way from me. Suddenly, as I was transfixed through all of these groups, the ASIM Bullying, Harassment and Sexual Discrimination Working Group, the AMA Equity and Diversity Committee, I find myself standing in front of you wondering what on earth I have done to be qualified to do any of this, but let alone to speak to you. Now, as I said earlier, I'm a white woman, I am English, I speak with an Australian accent. I acknowledge that I experience discrimination in a different way from you. So today I'm going to focus on gender inequity and the Dr. Two movement in medicine. I acknowledge that there are many of you in the room that experience discrimination in a different way to me. And while I want to be an ally to many of those people, that's not necessarily my story to tell. I don't want to take that story away from the people that live that every day. So today I'm going to focus on gender inequity and gender issues in medicine, and I will be happy to talk about any other issues that come up, but I'm not going to take that story off anyone else. So, to talk about where we've come, I think we need to talk about where we've been. And I think medicine in the good old days sounded pretty amazing, but pretty brutal. They did what they could with what they had, but ultimately it was all a guessing game. And I think many people still think it probably is still a bit of a guessing game. But medicine wasn't just brutal for the patients, it was also relatively brutal for the doctors. Now, this is the first documented English-speaking female doctor. Her name was Dr. James Miranda Barry. She was a medical officer in the British Army. She devoted her life to the Army, earning the highest medical rank available, Inspector General of Military Hospitals. She performed the first successful caesarean section in Africa, where both the mother and the baby survived. Brutal. But you may say something a little bit interesting about Dr. James Barry, in that she looks an awful lot like a man, which in its own right is completely fine, except she didn't identify as a man. She chose throughout her entire career to conceal herself as a man in an era where academic professions were the sole privilege of men. She lived her entire life throughout the army as a man. She even is thought to have conceived and delivered a child while working as a doctor in the army, never really revealing her gender until 100 years after her death, when the army thought it was appropriate to let everyone know. Medicine in 2018 is a lot brighter for women. We've had gender parity in medical graduates since 1990. That's 28 years. I couldn't believe that when I read that. And it was expected that we would reach specialisation parity by about 2008. We're a slightly older graduate. As medical universities are moving towards a postgraduate model, we're coming out graduates in a different stage in our lives. We've had prior careers. We're multi-skilled. We're coming out at a stage that might be more focused around family life or other skills. We're also more diverse with the changes that came in the 90s. We're getting more people from rural backgrounds, and people are bonded to work in rural backgrounds. Medicine is more accessible to people from a diversity of socio-economic backgrounds, and we have a high proportion of overseas trained graduates. But I'm sure this doesn't come as new information to many of you, but really it's why does it matter? And I wanted to get one of those cool photos where you've got the 6 and it says what everyone looks like, but I couldn't find it, so just use your imagination. Emergency doctor, I'm very black and white. Even though there's been a modernisation of the workforce, the workplace itself hasn't been modified in the same way that the workforce has. And I truly think this is where the Doctors Too, the Me Too movement has come from. We are functioning in a completely different workforce is functioning in the same workspace that's existed for 50 years. I'm not going to bore you with all the details, but bullying and harassment isn't a problem unique to medicine. It depends on the way the data is collected and how you define it, but there's no argument that it is well and truly overrepresented in health. We've known for a long time that doctors were suffering. The World Medical Association policy on bullying and harassment says that it's been a problem since 1980. I'm not sure how many of you were practicing before 1980, but I'm really sorry we came along and mucked it all up for you. We know that our younger doctors, that our female doctors and our internationally trained doctors suffer much more than most. We also know that the main perpetrator is usually our consultant workforce, and in particular our procedural specialists. We also knew that really it felt like to me as a junior doctor that everyone was too scared to do something about it until 2015, when Dr. McMullen made her comments about blowjobs and surgeons, and RACS stepped up and proved that there was a problem. Pretty quickly the AMA jumped on the bandwagon and they confirmed that there was a problem. And pretty soon after that, we had people coming out of all corners of medical education, of medical training, of medical practice, and suddenly we had a movement. We had a Doctors Too movement. The momentum was there. Now, this is meant to be a solutions-based workshop, so we really need to start talking about some solutions and where to. But before we do that, I think we need to think about why are we in this situation and why medicine is overrepresentation. I'm going to slightly counter you here, Louise, and say that I do think the hierarchy is a problem. A medical hierarchy is vitally important for patient safety. A social hierarchy within our profession is damaging, and it is the social hierarchy that our juniors are suffering in. We failed to modernise the workforce, which is what I was talking about earlier. We aren't flexible. Medicine is still, as a whole, and there are many of you that work outside of this, but as a whole, it's practiced between Monday to Friday, 8 till 6. Don't try and get an ultrasound after 2 p.m. any day of the week. We have things like telehealth, we have things like e-medicine, we have flexible work arrangements, but do you truly think that those things have modernised the workforce to the degree that our doctors have modernised in the way that we need to practice medicine? We're stuck in an eternal cycle where we're employed, supervised, taught and assessed by the same people. Our workplace policies are opaque. You can't see through them. It's an invariable game of smoke and mirrors. I can't even interpret my pay slip on a good day. And you want me to interpret a complaints mechanism? We still reward a culture where we suffer for our art, where we suffer for our patients. We work long, unsociable hours because it's the right thing to do. We work unpaid overtime because that patient needs to be seen. We haven't changed the system. We're just working harder, better, faster, stronger to try and deliver the care that we think needs to be delivered in 2018. But despite this, we still have some wins. And the Doctor Too movement has done some fantastic things for doctors of today. We've socialised the issue. What used to be a women's issue is becoming everyone's issue. And I think RACS should be applauded for taking it on and becoming the experts in the field and but going out and educating a lot of other colleges on why this is a problem and what they need to do about it. We've empowered a whole generation of people, not only by acknowledging that this is a problem, but by shifting the blame off the victim, which is what Louise was talking about, onto the people that are behaving in this manner. Operate with respect, not don't go near that surgeon. We've made people accountable. So professional organisations, RACS, ASIM, plenty of them. We've made the AMA accountable to gender and gender-related issues. We've made our employers accountable. Not all, let's get there. We've made the process a lot more transparent. We've made sure that people understand what's happening. I know that my college assessment processes have become incredibly more transparent over the 3 years. Our fees have also gone up 4 times, but that's okay. It's all about making sure that we have an equal playing field. What we have done by having a Doctors Too movement is we've set a cultural contract. We have verbalised what we think is a absolute basic level of behaviour, and people are being held to that behaviour across Australia. I think we've had a little win there. But we've also had some failures. The way that this movement was born was by the disempowered. The disempowered rose up and they pointed it out to people. And by coming up this way, we failed to bring some of the people along for the ride. And we can all picture them. That professor that doesn't think that that comment was actually all that inappropriate. Our female senior colleague who doesn't think that discrimination ever appeared in her entire time in their profession. The one college that said that bullying and harassment wasn't an issue in their college and they weren't going to do anything about it for their over 3,000 trainees. On their own, these people and these opinions are upsetting, but these become a problem when they're entrenched into this social hierarchy. Essentially, without changing the social hierarchy, we've created a system, we're behaving better in exactly the same system that we've been working in for 50 years. We haven't managed to empower those people at the bottom to speak up. We're just making sure the people at the top are a bit better behaved and hoping that they retire soon. For a Doctors Too movement to succeed, I'm going to disagree, again with Louise, and we should flatten that hierarchy. We should empower people to speak up and not have this yes sir, no sir, 3 bags full sir attitude. But despite this, where there's a will, there's a way, and I'm not here to speak about the will, I'm here to speak about the way. So I'm going to talk about my solutions-focused effort from here. I know there's a lot of text here, but I'm going to talk a lot as well. The data still suggests that men dominate leadership positions in medicine, and there's still evidence of a gender pay gap across medicine. In fact, they suggest that women are being paid 16.6% less for the same job as men. Argue that how you will, it's been validated. It's hard to be what you can't see, and despite huge advances in female graduates in the last 30 years, I'm still yet to work under a female director of emergency medicine. I'm still governed by an all-male board. And in fact, the only college that had more females than males on it in 2017 was Akron. At one stage, I believe they also had the only female college president. This is the medical leadership world that we are working in. These are the people that we are dealing with. I said to ASIM 3 years ago, it is inappropriate to have an all-male board. I was sitting on a discrimination expert advisory group looking at the ways that the college can change to include more trainees. And 3 years later, they've just elected, I think, the 4th male since that talk. Within my own backyard, things are no better. We still have plenty of women who have chosen to advocate on behalf of their female colleagues, but senior membership in the AMA is still very male-dominated. We've only ever had 2 female presidents of the AMA, and we've not had a female vice president in over 100 years. Without promoting women, without harnessing their leadership potential, we cannot advance. We just can't. You can't be what you can't see. We need to be teaching people to be leaders when they are medical students. We need to be harnessing the leadership potential that is already out there. And you notice that I don't want to be promoting people. I don't want to train people. There are already female leaders out there. We just need to make these positions accessible to those people. Don't have meetings all day Saturday, all day Sunday. Have teleconference. Have them in different hours that are family friendly. We need to call out our bad behaviour. By socialising the issue, if we don't make this everyone's issue, then it can be no one's issue. And this is what we did really well at the start, but we need to keep going because people start to think it's going away. It's not an issue anymore. You may have seen an article that came out last week about male mentors being too scared to mentor female trainees in case they got in trouble. My answer to that is if you're too scared to be a mentor because you might get in trouble, then change your behaviour or stop being a mentor because you shouldn't be scared if you're doing the right thing. We need to educate the people around us, and this saying that people hear over and over again, the standards you walk past, but that's really what we're doing by socialising this issue. We're pointing out the inappropriate comments, we're pointing out the inappropriate behaviour, so that that no longer becomes the person who is suffering that's problem, it becomes the whole room's problem. Someone points out something as sexist or inappropriate in a room, are you going to stand by and melt back into the wall? It's going to become your problem. Evidence shows that access to flexible training helps retain female trainees and that it is equally desired by female and male trainees regardless of their parental status. Until women can participate fully in the medical workplace, we will not have equality. And until fathers can take equal paternity leave or until both carers can take equal paternity leave, that is never going to happen. We need to change the way that we practice medicine to be more flexible and to reflect modern day life. We need to ensure that our employers and our colleges are held to a higher standard. This is the take a picture one, like Louise said earlier, if you're going to take a picture. We need our processes to be transparent. We need appeals mechanisms, assessment protocols, complaint mechanisms. They should all be shouted loud and clear. But most importantly, our assessors should be trained to assess. Our assessors should be trained to give feedback. They should be trained to mentor. Now, I have this slide in at the end here, not for any other reason than to prove that I have no greater authority than anyone else in this room to be up here, and perhaps less than some. This is my husband and I in our 1994 Defender on our wedding day in Kakadu. I really am just a simple country girl trying to make it better for all of us. In my 10 minutes up here, I was never going to solve this problem. In my 10 minutes up here, I was never going to fix this for all of us. But what I have done today is socialise this issue. And I have made this issue all of our issue. And I would like to implore all of you to take this message out, to take this back to whatever area you need to, your workplace, your training college, your professional body, whatever that may be, and socialise this issue and make this all of your issue. Thank you.
Thank you so much. That was awesome. In order that we
hear also what Jillann has to say, which I'm sure will be amazing. I'm going to take 3 questions. The people with their hands the highest that look like they're desperate, if anyone's got any.
Thanks. I'm a junior doctor in Newcastle. I was just wondering if you have any little tips for calling people out on inappropriate behaviour as a junior doctor, because you see it all the time, and maybe as a junior you have it's more obvious when things are inappropriate because you're at the bottom rung. But I also find it hard because often people are making jokes, and if you call them out saying that's inappropriate, that's sexist, that's whatever, that makes me uncomfortable, people are like, why won't you take a joke?
And look, it's really hard. I don't profess to be an expert, and I don't think anyone in this room does. When I was a 4th or 5th year registrar, I did an anaesthetics term, and had the worst experience of my entire life. And I put in a formal complaint at the end of it, and to this day it was the hardest thing I have ever done. I regret it every second. Every single time I see that anaesthetist in my relatively large hospital compared to some of you, but it is only one hospital in Darwin. I regret it, but I still think I did the right thing. I often think a simple, oh, well, that's a little bit inappropriate, and just going about your day often helps. I don't think there's a right answer. I think that as an individual, you need to decide how you best deal with that. And I have decided for me, working in a small emergency department with the same people day after day, the way that I do it is go, oh, we don't speak like that anymore. Or we say, oh no, that's a little bit inappropriate, I don't like that. Or I say, oh, maybe you should think about saying that next time you think about it. And that's just the way that I have chosen to make my feedback non-confrontational. There are still times I go home and kick myself for not saying what I wanted to say. I go home and think of that perfect comment, and there are sometimes I go home furious. But I think you need to know your worth, know your value, and know that your opinion about what is and isn't appropriate is just as valuable. It does not matter where you are in that social hierarchy. As long as we respect the medical hierarchy is there for safety, that social hierarchy is a construct of medicine, and you are just as entitled to your opinion as anyone next to you.
While I walk to the next person, I'm also going to say that it's okay if you don't feel like you can say anything.
Absolutely.
And find your champions that you can go to and say, actually, this is not okay, can you help me here? Because you're in a really disempowered position. And humour helps. So I was an intern with some surgeons who would invite all the male students to their house for teaching sessions and not the female students, and they were pretty brutal to me as an intern. And I had an older female student who became my inspiration, and he it was so classic, patted the boys on the back one day, and she ran ahead on the ward round and she went like this. And he went, what? And she goes, do I get one of those? Or am I the wrong gender? And it was very powerful because he went, oh, ho, ho, ho. And I was like, go girl.
Hi, just responding to that one, there's a lot of initiatives about how to respond to racism, sexism, all these things that we actually struggle with. And a few things that I found useful is stuff like pretending to be ignorant. And then you ask them, sorry, I don't get that. Could you explain that? And then it forces the person to actually then think, and often the response is they become quite uncomfortable, and then it's on them. So I found that quite useful. And my question was just about the psyche of perhaps some of the female senior doctors who are involved in perpetrating the trauma. If there's any thoughts about, I have, I guess, suspicion what I think are some of the reasons behind that, and perhaps a bit of transformation of trauma from them that they've suffered. But I wondered if there's actually any studies on them.
Louise is gone. I was going to say, look, I don't know of any studies on that. I'm sure they exist, but please forgive me, my experience is very much in policy and less so in research. My experience, and I perhaps have a slightly different, not only through my training network, but also through my experience in the AMA, is that many of these women feel like they, and I've had these exact words, so please, I don't want to feel like I'm putting it in people's mouths, but they've suffered through it, and they were fine, and they got to where they did, and they weren't helped to get where they did, and they didn't see what was happening happening to them as discrimination or bullying, so they don't often see what's happening to us as discrimination and bullying. So it's about changing that culture. It's about bringing them along for the journey and not cutting them out of the journey, because I don't think that's how we've learnt from the anti-vaxxers, it's not how you win any argument, is it? So I don't know of any research, I'm sorry, but I recognise the issue.
Thanks, that was a great talk. I don't know if you were at breakfast.
No, I'm very sorry. I flew in at 1 a.m. from my board meeting, so please forgive me.
I don't know if I'm being too sensitive, but the MC, I'm sorry, I don't know his name. There was one person on the plenary who didn't come, and she was a woman, and the other 4 were men. And he made a joke about her being late again, and everyone laughed. And then he said that she was probably at the bar arguing with about a games night. What was he? Trivial game, and that she was arguing about something about the Eurythmics, and everybody laughed. And I thought, yeah. And he made a comment about her being grandma, and I thought, am I being too sensitive about this, or would he make that joke about a man? And then I thought, that's wrong. Even if he made a joke like that about someone being late who's got a position of power, she's an ex-president, I don't know her at all. But even if it was a man, that would have been... Yeah, but even if that was a man, that was an unprofessional thing to say and very bad of the MC. And I felt really uncomfortable about that. You're not being too sensitive. Oh, sorry? It's the only unprofessional moment, I think. Yes, so the MC this week, well, anyway, I think all of those little things. And we have to judge people on now. So those older women who had to work 80 hours a week and put up with rubbish, and they had to do that. But we're judging things from now. You know, we all don't speed, we all wear seatbelts, we all don't drink and drive. Things have moved.
I think this is about normalising the problem. And I was at a board meeting yesterday, and one of our wonderful past presidents turned to me and she said, well, of course you are, darling. You're the only one left from that committee. And we went on with our meeting, and I thought nothing of it. She's a close friend of ours, of my partner and I. Her husband and my husband are related. I thought nothing of it. And after 5 minutes, she turned to me white and she said, I'm so sorry I called you darling. She thought it was completely inappropriate. I wouldn't do it to anyone else in the room. And I think what shocked me the most was not that she called me darling, because we have a different relationship, but because I didn't notice it. It had been normalised for me to be called, especially in something like the AMA, who I do champion and I am a big advocate for. But as someone who's 30 years old and 5'1", you don't often maybe get the respect of the person sitting next to you. So, thank you.
Thank you so much. That was awesome. The good thing about when things go like that at conferences is that we all have evaluations at the end, and we should use them, I think. So I think our last speaker probably doesn't need much introduction after her amazing keynote yesterday. Hopefully most of you got to that, but I'm just going to take the important bits in case you didn't. She's an Australian GP and health service manager who followed her heart, believed in herself and took a giant leap into the Directorship of Medical Services Division of the United Nations. For the students and pre-vocational doctors in the room who are undecided on your future career, she's a great example of where the skills you acquire in generalism, where they can take you. She's also a martial arts instructor and once had to push her 188 centimetre tall boss into a taxi while dealing with the guy who was trying to assault him, all the while in heels, a pencil skirt and not dropping her briefcase. Welcome, Jillann.
Hi everybody, and it's great to see such a crowd here. I would like to say that story was suppressed for several years while my boss came to terms with it. He sat in the taxi, because I climbed in after him once the assailant was on the ground. I sort of stepped over the top of him, got in the taxi and we drove away. Keeping my knees together, of course, so that he couldn't look up my skirt. But my boss just looked at me and said, what happens on camp stays on camp. You can never tell anybody about this. And so I never said anything about it to anybody, including even my husband, who probably would have thought I was completely insane for putting myself at risk. And then my boss surprised me one day. We were co-presenting a course, and part of the exercise was to introduce something about your partner, and he chose to tell the story. So it took him a few years to process, but we got there. So it's great to be here and to see so many people at so many different career stages. And I'm weirdly, I don't see myself as an expert in this area, but I have a lot of lived experience. And in the UN at the moment, the Secretary-General is leading us on a dialogue about dealing with harassment, not just sexual harassment, but all forms of harassment. And one of the things that I'm extremely proud of, because it has been a momentous task, is that for the last 5 years I've been working on the development of a mental health strategy to look after the mental health of the men and women who serve the UN. And the nexus between harassment, gender-based harassment, and mental health is very clear. So last week, the Secretary-General launched the mental health strategy. It was a fantastic thing to have his very strong personal endorsement of it. And the next day, he hosted a luncheon where he highlighted his anti-harassment initiative and the mental health strategy as two of his landmark internal reforms that he wanted to undertake. And there was a speaker there who rocked my world a little bit, but it made me realise that she was right. Because what she said was, there will be no women in this room who are over 15 years old who've not been sexually harassed, touched inappropriately, or sexually assaulted. It affects all of us. This is not a medical problem, it's a societal problem. And it is not something that seems to have been solved comprehensively, even in sort of the place that I work, that is supposed to be the palace of all of the best things about humanity, but on occasions can be the melting pot of some of the worst. So when I think about that, and I think about my own personal experience, I was sexually assaulted for the first time when I was 12. I was in a swimming pool. There was an older boy in the swimming squad. He was about 16, and he thought that the right thing to do was to shove his hand under my bathers and try and convince me to date him. And I've never had a great deal of difficulty speaking up, so I told the coach about it immediately, and I may have been fortunate because that first disclosure, I actually had a female coach, and so she dealt with it appropriately. And instead of ostracising me, he was the one over in the naughty corner of the pool doing his laps alone. So the very first experience of how you will be dealt with when you disclose, I think, can shape the trajectory. And so I think recognising that first intrusions can occur at an extremely early age, we actually need to be making sure that very young women and girls have a safe pathway to report to someone who knows how to respond appropriately and to not punish or shame them for the disclosure that they made. When I was in med school, I spent my first 3 years just being a pretty normal medical student, but getting progressively, I have to say, more and more bored, because the medical curriculum wasn't really feeding a part of my brain, and I know that in retrospect now. So in second year, I campaigned and became the medical student representative on the Student Union Council. In third year, I was elected to the executive, and at the end of my third year, I ran for and was elected president of the Student Union of the University of Queensland. And I was the first medical student, I was only the second woman to hold that office. I was the first undergraduate woman to hold the office. The only other woman who'd held it had been elected after she'd graduated and was a postgrad student. And I was the first medical student to hold it since it had become a full-time job. So I took a year off and immersed in this incredibly different environment for a whole year. And a whole world of advocacy and gender politics and dynamics that I didn't have exposure to in the medical course opened up to me. And I had an opportunity to develop strong friendships with some people that to me seemed like incredibly hardcore, radical, leftist, feminists. Totally not the sort of people I would have normally hung out with as I wandered the campus in my pink skirt, white blouse and little boater hat. That was me at that time. But that diversity of experience opened my eyes to the possible. And when I went back into med school, I went with a different toolkit. And it was about exposure and opportunity. And I remember in fourth year, we were in pathology lecturers, and I will never forget this because I think it was the first time I really spoke out to power. The lecturer was delivering a lecture about, I think it was a pathology lecture, and he was delivering a lecture about urinary tract infection. And he made a statement about the inherent defects of the design of females, their urinary tract, and of course their brains. And I sat there in the lecture fuming, and then I just went up to him at the end of the lecture and I said, you need to know that that was really inappropriate. Imagine if you had made that statement about Jews or Indigenous people or African Americans, you would be called out as a racist. So I'm calling you out now. That was a really sexist comment. And I just walked away. And I thought, what the hell? I've already roasted because I've taken a year off. I'm probably never going to pass exams anyway. But he actually responded in a way that surprised me because he was an incredibly brash, abrupt person. But that challenge helped him to see himself and what he thought was a harmless joke through a different pair of eyes. And I never saw him repeat that behaviour again. So that was, again, another lesson in a way to respond. Subsequently, and here's another Me Too moment, I was sexually assaulted by 4 of my male colleagues in medical school. And it was a really interesting experience because in the moment I didn't recognise what was happening. It just didn't process. I didn't recognise what was happening. And it was only in moments of quiet reflection several days later that I realised that what they had done met the legal definition of sexual assault. And I had a choice to make, and I felt able to make that choice. So I chose to report, but I chose to keep control. So I went to the university, and again I had the benefit of reporting to a person who received appropriately, who treated my document, who responded, supported me, documented and assisted me to make a formal complaint to the university. And that's where things bifurcated, and it was very interesting. The dean of the medical school called me in and said, "Are you sure you want to do this? It's possible you will never work in Queensland again if you do. And I would counsel you against it because it's really not going to help your career." And I just took a breath and said, I want to do this. I want to report this. The response of the university outside of the medical school was swift and ferocious. And I will never forget then Sam Rain, who was the registrar, and he took each one of those young men into his office and made it very clear to them that the fact they would have a career in the future was a gift from me. Because I could have chosen to take them to criminal prosecution. That thing had been witnessed. But those men have careers today because I chose to give it to them. And that was an amazing, empowering thing to do. I wasn't forced to report. I wasn't forced to take it down the criminal pathway. But it was dealt with respectfully and in a way that I felt confident that those young men had learned that where the boundaries lay. And again, I never saw anything of concern from them. But the blowback came from their female friends. And so it was their female friends who said that I was disgusting. It was their female friends who said that I had abused my connections derived during my period of service as student union president, advocating for them, that I had abused my contacts to somehow make up a spurious complaint. And the furthest I went in dealing with that was simply to say to them, I could have called the police and had them criminally prosecuted. You can thank me that I did not. And then the harassment from female colleagues stopped as well. So not everybody is going to have had that pathway to learn to be assertive, to learn that you can do this in safety. And I recognise that. So one of the things I've been thinking about is, what was it that allowed me and supported me to do that? And I think part of it was that very early experience of disclosure to a coach who knew what to do, who did the right thing and didn't make me seem as though the person I had done was the wrong thing. But the other thing that it caused me to reflect upon is and again, I made a sweeping statement about Australia and racism yesterday. I'll make another one about Australia and misogyny today. But I'm in good company, Julia, so... I was working at the UN for about 6 months, and I was just trying to work out why I felt different. I'd never worked outside Australia for a prolonged period before, and I just felt a little different. And I realised that it had been 6 months since I'd had to apologise for the crime of being female with an opinion. And I had that environment, and I hadn't even noticed it until I was no longer in it. It's a bit like if you're swimming in murky water, you don't really know what clean water is like. You don't know what it's like to dive with 30 metres of visibility if you've only ever dived in 2 metres of vis. So that's been a source of considerable reflection for me as well. And I do think that there are societal expectations on women in Australia. And I don't think that everybody has the same experience as me. But my experience was that male sponsorship was necessary to be allowed to take leadership. That male sponsorship was necessary if I wanted to express an opinion. And that in some ways, and here's where you'll hear my separatist feminist past bubbling through, the patriarchy needed to understand that I'd been neutralised by being put on a leash by a man that they trusted before I could be put into a position of power. Now that's the most radical interpretation of it, and it may not be true, but it is one possible interpretation of a repeated experience that no matter how good what I had to say was, it wouldn't be listened to until I had a powerful male sponsor. At the UN, it's not like that at all. But it's not nirvana either. And I have had male colleagues make belittling and demeaning comments about me in front of people. And I give them the dignity of a private dressing down before outing them publicly. But they always know that the next time it happens, I will destroy them in public. So another one of my reflections was that a lot of harassment happens in private, but a lot of it happens in front of other people. And we say nothing. We turn our faces away and we do nothing. And in so doing, we become complicit in the perpetuation of this. And so one of the things that in my environment that the Secretary-General has been really working on is having all of us recognise that the person on the receiving end may not be failing to speak up because they are in agreement with what's happening. They might be like me and not recognise in the moment because they're too shocked. They might not feel safe to do so. But there may be in every group a person who has nothing to lose, who really can speak up to power. So if you're on a surgical rotation and you know you don't want to be a surgeon, then stick it to them. You know? What have you got to lose? So you have to find your little pieces of power and use it on behalf of other people. And so when I was doing a surgical rotation and the surgeon was harassing my Vietnamese friend because she couldn't recognise a quote out of the Bible, I said to him, let's play tit for tat and let her give you a quote out of the Book of Buddha and see how you do, because I knew I didn't want to be a surgeon. But he shut up after that. You know, so sometimes it just takes recognising that there's something going on here that I can't tolerate. And you can make a decision. I'm not saying everyone can always speak out at every moment. I certainly haven't done that. I'm not holding myself up here as some super saintly, always right advocate. But I have chosen moments where the risk and the benefit really worked for me, that I wasn't putting myself at personal risk by speaking out, but I was able to help someone else. One of my final reflections is that it's great to see that we have some men in the room. Because it's easy for a session like this. No, seriously, it's really easy for a session like this to become all about that it's the men who are the problem. But the UN has, and UN Women has, a movement or a program called He for She, recognising that that gender perspectives are about making sure that experiences are good for men and women. It's not about making men's experiences worse so that women's can be better. It's about creating a world where everyone is equal, regardless of race, gender, religion or nationality. And men are part of the solution to this, because imagine how powerful it is if a male surgeon is harassing a female registrar and a male resident speaks up and says, that is not okay. So it doesn't only have to be women who speak out. And I've been so proud of Australia on occasions when I've seen bystanders intervening in some of those racist tirades that you see on the buses. That, you know, it's so good when bystanders act, and we do have the ability to create places of safety. We can't all act all of the time, but every one of us can act some of the time. Even if it's only once, it might be a life-changing event for the person that you have stepped out to try and protect. So in summary, you know, one of my briefs was, you know, how are the ways that I've dealt with as a manager? And I've actually erred off that to talk a little bit more about a personal journey, because in fact, as a manager, I've had more reports from female doctors of harassment by patients than I have of harassment by colleagues. And so whilst I know that the gender and power dynamics within the profession and training are certainly an issue that we have to deal with, I think we've also got to spend a little bit of time thinking on what are the expectations and roles where a doctor is sexually harassed or even sexually assaulted by a patient. Because in that, there's an even more profound sense of shame, because the doctor's supposed to be in charge. We voluntarily lock ourselves in rooms alone with people who may not be safe for us to be with, and we may not realise that we're not safe until it's too late. Most general practice consulting rooms don't come with a duress button. Most of them don't have a second exit. Most of them don't have security outside. So we work in particularly vulnerable environments. And so one of the things that I've started advocating for within the UN is that we actually need specific guidance for health practitioners who are harassed or assaulted by their patients, because oftentimes those practitioners don't feel that they can breach the confidentiality of the consulting room by making a report. So that's one thing that I've been involved in, and of course, as a person who works for the UN, it is always my obligation to be a gender champion, and I do the best that I can. I don't have solutions, I'm not an expert in this, but what I have had is some experiences about what has worked for me that has helped me hold people to account and recognise that we will all have little moments like that, and maybe in the coming weeks and years you will recognise a little moment like that where you have power. On one occasion, for a millisecond, you have power, and that's the time to use it to achieve some good.
Thank you so much. As probably predictable, 90 minutes is not long to talk about this, and I think it's the start of a conversation, and maybe our next year's workshop probably we will continue it. So we've got time for some questions and also maybe some thoughts, and maybe that can kind of inform a media statement if you're happy with that. So if you've got a burning thing that you would like to see in that, let us know. It's very short, so we'll continue this conversation at lunch as well, and hopefully we'll continue the conversation forever and ever until we achieve the goal. Do you want to speak up? In the big auditorium every time. Sure.
My name's Sue Harris, and I'm currently one of the female board members of ACRM. And, and this workshop came out of a meeting last year in Melbourne's RMA when our female doctors group had lunch, and one of the discussions was about the bullying and harassment and sexual harassment in the workplace for our female doctors. So for the young women who promoted this discussion, thanks very much for pushing us along a track which obviously has a lot of attention within the college. So my question to you is, well, firstly, what I'd like to say is you are part of the solution, and you can only do that by putting yourselves forward to be leaders within this arena. And so join your local RDA and have a say within the college. But how would you like us to take it forward? Bek and I, female doctors group, well led at the moment by Bek, and that's not a big commitment. It's a teleconference 4 times a year with doctors from all over Australia. So please step forward, be part of the answer to these problems. But Bek, we've talked a bit about having a press statement, and would certainly love to have something come out of today's meeting for the college hierarchy to consider. So I guess that's one of the things that I'd like you to be having a think about in these next few minutes.
I'm going to go back corner, getting my steps up.
Thank you all for such an amazing speech. It's very surreal to sit here in a room full of women, you know, and the men. Like every time I saw a male walk in, my heart skipped a little bit. I was, thank God you're here. I guess not a question, but more of a thought and personal experiences. I'm a junior doctor in Queensland and did medical school through there. And if I had $1 for every ward round where I was referred to as the pretty young nurse in the corner, I'd probably be not working currently. And if I had another $1 for every time my seniors said nothing, or even worse, laughed or continued the conversation in a joking manner, referring to me as, you know, their pretty young student or their pretty young intern. And it's challenging to confront that because it's sort of a backhanded compliment, you know, you've been referred to as pretty. But it's also quite demeaning, you know. I've done 6 years of study. I worked very hard to get where I am, as has everyone in this room. And so to not be acknowledged for that, not being acknowledged for that professional capability that you have in comparison to your seniors. But the most devastating thing is that your seniors, who are meant to be your supervisors, are not standing up, and in those cases are encouraging it. And I guess I'm lucky that I am, you know, and similar to what you're saying, have a voice. I am able to stand up in majority of the time. Sometimes it's difficult, but I know a lot of my female colleagues can't. And medical students, junior doctors, can be very vulnerable. So I think we need to, in some way, those that are, you know, confident to have the voice need to stand up and encourage others, encourage our supervisors and our senior consultants to have that zero tolerance, to make those simple comments that you mentioned earlier that, oh, we don't talk like that anymore.
I have, I don't know whether there's a solution to this, but there's a case that I had. I'm just recently fellowed. I was mentoring an intern, and she had worked at the same hospital that we were at as a student, and she was put with a male senior registrar to sort of pair up with while she was on her emergency rotation. And he stalked her quite severely. She ended up doing a John Flynn placement as part of her thing, and she went to a remote area, and he ended up asking her what was she doing on her holidays. She was fairly relieved to sort of be like, well, actually I'm going way, way away, so you won't be able to sort of get in contact with me. And while she was driving there, she got a text from him saying, guess what, I've picked up a locum at the same hospital where you're doing your John Flynn placement. And then she didn't know what to do. She didn't answer the text. He then continued to harass her, saying, would you like to come to my hotel, bring a bikini, I bet you'd look really attractive in a bikini, and was really being quite confronting, and it got worse and worse and worse, and she didn't know what to do, so she just ignored it. Eventually it stopped. She had to defriend him. This guy was married with a family as well. Not that that makes a difference, but it got to the point where she basically was almost about to have a mental breakdown, and she confided in me sometime later. So that was at the end of her final year of medicine, and she confided in me while she was doing her internship, and that doctor still worked there, and she was worried about that. So I encouraged her to report. She refused because she said that wasn't something she could do. She was afraid because everybody loved this doctor and he's such a great guy. And so I felt a responsibility to say something about it in a confidential manner. So I didn't want to break her confidentiality, but I was also concerned about whether or not this was going to happen. He was still getting paired with medical students. And while nothing had happened with her, I thought this is really just asking basically for trouble. He's going to get to a point where he's going to, assault somebody. So I spoke to one of the female bosses, telling the story and that the doctor that was involved, but not telling about the female person that was involved. And she said there's nothing she could do because the person wouldn't come forward. And so therefore it was just hearsay, and it was defamation of him if they did anything. And I just said, can we just stop giving him students at least. And she said, no, that's still just hearsay. So I don't know if there is some way to have some type of a reporting system where you've got these people, they don't want to do anything about it, but by not saying anything, I guess they're putting other people at risk with these dangerous people. I didn't know where to take that because I couldn't escalate that without outing her, which was not something she emotionally was prepared to do. What do you do in that circumstance?
I would like to say something on that, and I know there's heaps of people want to say something, but I think Louise commented before about an outside person, and I think in those microcosms of hospitals it's really difficult. And I think at this conference, at RMA, I can speak for RDAA and for ACRM that, and it's no mistake that we've got somebody from the AMA here, because I think you need to find champions outside of the microcosm where it's existing when you can't speak up, and triangulate it. And so we had in Louise's talk yesterday, we had a story about not putting in a formal complaint in the system because it wasn't safe, but going to the AMA, and the AMA bringing the formal complaint, and there were sanctions applied at that point, because you need to have some champions with you. And when you're junior, if you can't speak up, that's okay. That's what we really wanted to say today, is that you won't always be able to. It's unsafe. But as somebody that found my champions when I was a junior doctor needing help, including the AMA, including the Female Doctors Group, I've now gotten to a point in my career where I can be that for other people. And I think one of the solutions is to find your outsiders to help you as well.
It's very hard though, because anyone who knows me will know I've never had a problem with speaking up, and have had a difficult time through my career through actually advocating for what I believe is right. And I choose my...
Anyone who speaks up has,
yeah,
I think. You're not
yeah.
rewarded for speaking
It's and not many times I've thought about quitting because of the trouble that I've had through doing what's right. I've even saved children's lives and been criticised for having to escalate things. But I don't have a problem with advocating, but she's not going to do that. But I still have a concern about doctors' safety. I don't know what I can do in that.
Like, I don't know that individual situation. I don't know but we just need to change that culture.
I think that there are just two comments I have on that. First of all, don't underestimate how much you added to that situation simply by validating that junior doctor's feelings. I found myself in this situation often, especially recently, that they come to me with their problem, and even just by saying, that is horrendous, sometimes that is what they need to hear. That doesn't always solve the problem.
She came to me because she knew I felt with that person.
Yeah.
Everybody else in the department loved that person, but I had advocated against him on a prior occasion, which is why she felt that I would believe him.
The second side to that is sometimes this is out of the individual doctor's hands, and RACs have introduced their Operate with Respect program, comes with an ability to anonymously report surgeons for their bad behaviour. So you can anonymously say, this surgeon did this, these are the details, this is the horrible thing, and they've investigated every single situation that they have got through that program. Now, do we need to call to our colleges and say, do we need to have this? Does this need to be bigger? My recommendation is that APRA is perhaps not the right place for that. I think we should stay very separate from that, but do our colleges need to say, if there is bad behaviour within our ranks, if one of our fellows is behaving badly, we need to know about that, and I would call on the colleges to step up there.
His college or...
All of them. Like, why should we say just that one?
She's not in a college.
But all of, yeah.
I don't even know if he was in a college, to be honest. I'm going to just move on from this.
I just wanted to build on what the lady in the corner, junior doctor, I think, yes, was talking about. And as a junior doctor, I regularly got the sweetie, honey, miss, whereas my male colleagues would always get doctor. And that came from the top. It also came from your patients. I still get, hi, I'm Dr. Lauren, and they still go, oh, it's nice to meet you, sweetie. And I think that there needs to be a cultural change from both perspectives. Consultants calling you sweetie or honey or whatever endearing term that they think is actually harmless, it just completely degrades your work, for one. And they think of you as the pretty little intern or the pretty little nurse in the corner, and it really is very it's degrading, and it undermines everything that you've done. And I mean, I work with a number of male colleagues. My practice is older male GPs, and I've never ever had a problem with them whatsoever. They are wonderful, they're respectful, and they would never dare to call me that. But patients regularly will refer to it as Dr. So-and-so and I'm sweetie or honey. And it's the couple that I have called out and gone, I'm a bit cranky today, I'm just not dealing with this, have actually questioned their behaviour and have not actually realised that they are actually doing it. And so I think it's one of these things is how do we actually change that culture as well, that women can actually be doctors?
Yeah.
I think.
Okay. Hi everyone, I'm Kirsty. I'm one of the ACRIM registrars. I'm also a ASOM refugee, still partially with college. Two things, like what ACRIM can do for us in terms of actually developing leadership, and particularly the pastoral role. That's been lost, particularly in the ED setting. We don't have that pastoral role that should be part of our duty as senior clinicians. We should know how our students are getting on, and we should be checking in to make sure they're not bullying and they're not being subjected to sexual harassment. I currently have my eyes on my team at the moment and checking in to make sure, because I know there's one doctor that's been a bit of a problem, and I've actually taken that doctor aside and said, look, you're being perceived as a bit of a jerk. We're going to see how you go, but if I hear any more problems, then this is going to be channeled up. The other issue is, and I think it was spoken about earlier on, was gender politics, and in terms of why do women savage each other, and there's a lot of writings about this. Essentially, look, we do still occupy quite a lower socioeconomic status compared to men. So for us, for other women, the way to climb that ladder is to take others down down around them. It's like the lowest hanging fruit. So we do ourselves a disservice. And actually, if you talk to any of the junior doctors, sorry to point out groups, but female nurses are really savage to female doctors. And if you look at what happens, like even the men are horrified. So we've all got to pull together, and we've got to start changing the culture, and ACRIM can be part of that. Curriculum? Yeah, it has to be part of the curriculum, how to build stronger leaders and how to best serve our teams. Next.
This area I haven't really been very good at, sorry.
Thanks. My name's June. I'm a PGY3 doing my AST in Pop Health, and I'm based at Stanthorpe Hospital, and I'm very fortunate right now in my current workplace. I've just been thinking about it in this session, and we have more female SMOs than we do male, and our male SMOs are delightful, and they have been more than supportive, particularly when you have that inevitable patient who does the nurse or the pretty young doctor, and they regularly very quickly call it out, and they're like, no, this is June, she's our doctor, she's very competent, please treat her with respect. And I'm very fortunate, but by the same token, I think some of our kinder, I guess almost more equitable male colleagues, they don't, particularly in my workplace, they don't make a distinction between male and female doctors. You get treated as a competent individual, and that's what you get. But I don't think, I've had a couple of conversations probably in the last 3 months that's really pointed out to me that they don't always realise what's going on. So I've certainly, with one of my senior SMOs, one of our junior relievers and I were discussing our war stories from our junior relieving terms, and we were discussing just the regularity of being yelled at 10 o'clock at night when you've been on call for 48 hours and you're a bit you're at the edge of your tether because you're exhausted and you're PGY2 and you're really being pushed with no supervision on site. And our SMO, male SMO, just sat there and looked at us, and he was shocked. He said, is this because you could just see the light bulb moment. I've never had a moment like that, he said. Is this because you're female? And we just went, oh, maybe it is. We just assumed it was a junior doctor thing that and this is the other thing that horrifies me, is that you get yelled at 2 o'clock in the morning, and the statement that goes with it is, I just got yelled at and maybe I deserved it. Well, do any of us deserve to be yelled at? Isn't that wrong that that's now so ingrained in us that we just accept that being yelled at by a senior is appropriate? I think that's really wrong. And the other conversation I've had probably in the last month with a couple of my interns, the interns came over for dinner, and my female intern and I were discussing our choices of clothing and the amount of thought we put into how we present ourselves at work. so that we try and minimise the sexualisation. So I habitually will choose to wear slacks and a fairly loose shirt because I'm little. I don't want to look more feminine than I already look because I'm really little and I look a lot younger than I am. So the comment of, you look too young to be a doctor, and you're like, I'm nearly 40, that's not an appropriate comment. And my other intern is slightly... She's a much more rounded young lady, and she's like, I can't hide this, so I dress in a very 40s housewife. You can't hide the girls, they're going to be there, but I try and do it in a professional manner. And our male intern sat there, and I've never seen someone get so angry, and he's like, you should not have to think like this. And once again, you could just see in a very pleasant male who doesn't really make that distinction is that cluelessness, and I'm pretty sure every female here would think very carefully about what they wear to work, and the shoes that you wear and the top that you wear. And I just think maybe we need to sort of, and our male colleagues who aren't the problems are also to a certain extent clueless.
I think those comments are quite linked by the fact that we need to tell people about the problem. There's also so I have to just confess to you that it's lunchtime, so we do need to wrap up, but I'll take 2 more comments if everyone's happy with that. Can I be the last one? We haven't had a man yet. Okay. Well, that's probably more... Do you want to be the last one? Yeah, I would like to be. Yeah. Okay. She's chosen to be last. And so I'm so sorry for everyone who hasn't had the mic.
Thank you. I'm from New Zealand. I'd like to say that if this was in a Kiwi environment, we'd probably have a lot more men in the room. I think Australia's got a wee way to go, and I think having grown up in the 70s and 80s and seen this whole shift in race relations and gender issues as well that's taken place. But I'm trying to think of a solution, and I'm in the Royal Hospital Medicine Fellowship in New Zealand, and on our 3-year triennium we have to do a cultural awareness safety element to that, and it's really useful. It will go into Maori issues and the Treaty of Waitangi and so on, but also other cultural issues because of the change that's taken place over the years. I just wonder if that's one place, because in those cultural safety issues, you see role-playing and so on, and it makes you aware, gosh, do we do that? Did I do that? Whereas if everyone from the professor of surgery right down to the bottom has to sit there and do it as part of their triennium and actually sit there and see a role play and a young woman talking about, notice I said woman, not lady, and that's the other thing about Australians, you talk about girls and ladies, it's woman. I was in the pub last night and this guy said to all these, can I help you girls? Fuck, if that was New Zealand, they'd get smacked one, Anyway, that's just a suggestion.
So as I walked to the last comment, I'm from New Zealand, and my dad used to, at barbecues, all the men would go outside and Dad would be like, what goes on here? I want to be here cooking. And we were blown away by the misogyny when we got to Australia. Dad was made fun of for doing women's work. Anyway, we're getting there. We are getting there. Last comment.
Sorry. It's hard to resist social media. I'm Annabelle Brayley. I'm really actually delighted to say I'm another female member on the board of ACRM. I'm also not a doctor. I'm actually a community director, newly appointed. But one of the things I wanted to say to you last is that a new friend, Dr. Melissa Naidoo, who's a doctor in Brisbane, and some of you will have heard of the social media thing on Twitter last year celebrating women. Maybe not, but the purpose of it was in a world of a lot of negativity and criticism of women and lack of recognition of their value and worth as women, that thread began. Melissa and I are planning to start a new thread next year which will be celebrating women in medicine. And my side of that in Australia, well, not necessarily in Australia, but that's where we'll start. But my part in that is going to be, in particular, encouraging women in rural medicine to step up and be a part of that, so that we're not just always looking at the negative side of what you do, but that we're celebrating all the wonderful positive things that you do. So as a community consumer, thank you.
Thank you so much, everyone. If you want to contribute to the statement, I'll be around. Thank you so much for filling the room. Let's continue the conversation and go eat lunch. Oh, the piece of paper that's going around is if you want to join the female doctors group. You don't all have to put your name on it if you don't want to join.